Hey everyone, this is Pharmacology Simplified, and in this video I'm going to break down concept of pharmacokinetics and we'll do an overview of how drug gets absorbed in the body, how it's distributed, how it's metabolized and eliminated. Pharmacokinetics is the study of how body processes a drug, often described as what the body does to a drug, as opposed to pharmacodynamics, which is described as what a drug does to the body. Pharmacokinetics refers to the movement of the drug into, through, and out of the body, the time course of its absorption, bioavailability, distribution, metabolism, and excretion. This leads me to the basic principles of pharmacokinetics: absorption, distribution, metabolism, and excretion. Absorption is the process that brings a drug from the administration, for example from tablet or capsule, into the systemic circulation. There are many possible methods of drug administration, including but not limited to oral, intravenous, intramuscular, subcutaneous, buccal, inhaled, nebulized, transdermal, and each administration method has its own absorption characteristics, advantages, and disadvantages. Unless given intravenously, a drug must cross several semi-permeable cell membranes before it reaches the systemic circulation. Cell membranes are biologic barriers that selectively inhibit passage of drug molecules. These membranes are composed primarily of a bimolecular lipid matrix, which determines membrane permeability characteristics. Drugs may cross cell membranes by passive diffusion, facilitated passive diffusion, active transport, and pinocytosis. In passive diffusion, drugs diffuse across a cell membrane from a region of high concentration to a region of low concentration. Diffusion rate is directly proportional to the gradient, but it also depends on the molecule's lipid solubility, size, degree of ionization, and the area of absorptive surface. Because the cell membrane is lipoid, lipid-soluble drugs diffuse the fastest. In regards to size, small molecules tend to cross the membranes faster than larger ones. When it comes to degree of ionization, most drugs are weak organic acids or bases existing in unionized or ionized forms in water environment. The unionized form is usually lipid soluble and it diffuses faster across cell membranes. Now, some less lipid soluble molecules like glucose cross membranes faster than anticipated. This can be explained with facilitated passive diffusion, which can be seen in this slide. So what we see, a carrier molecule in the membrane temporarily combines with a substrate molecule outside the cell membrane. The resulting complex of carrier plus substrate moves across the membrane and releases the substrate on the interior surface. This process is selective. It's limited by the availability of carriers and it doesn't require energy. Importantly, it doesn't allow transport against the concentration gradient. Active transport is the movement of molecules or ions across a cell membrane from a region of lower concentration to a region of higher concentration. Active transport mechanisms require cell's energy, usually in the form of ATP. This type of transport is for larger molecules that wouldn't fit in a channel or a pocket of a carrier, and it's mainly for drugs similar to natural substances such as vitamins. In pinocytosis, fluid or particles are engulfed by a cell. The cell membrane encloses the fluid or particles, then fuses again, forming a vesicle that later detaches and moves to the cell interior. Only a small amount of energy is needed. When the cell engulfs substance in, the fluid gets stored inside a vesicle. Basically, this vesicle is a membrane-bound organelle that's made from the same lipid of the cell membrane. This type of transport is for protein drugs. Now let's talk about bioavailability. Bioavailability is the fraction of the drug that arrives in systemic circulation. It depends on the properties of the substance and the mode of administration. Bioavailability is a crucial component in pharmacokinetics, as less than 100% of an orally administered drug is absorbed, with some undergoing metabolism in the gut and liver. F is the symbol for bioavailability, and it is usually presented as percentage of the dose. For example, a bioavailability of 80% means 80% of the administered dose reaches the systemic circulation. This equation describes the fraction of what ends up in the systemic circulation as compared to some sort of maximal possible systemic circulation. Bioavailability is also often estimated with the area under the plasma concentration time curve, which is also known as area under the curve, which is also the most reliable measure of drugs' bioavailability. Area under the curve is directly proportional to the total amount of unchanged drug that reaches systemic circulation. Two drugs are equivalent in regards to bioavailability if their concentration curves in the bloodstream are nearly identical in terms of both the amount and the speed of absorption. The amount of drug in the bloodstream goes up as it gets absorbed. The highest concentration happens when the rate at which the body removes the drug matches the rate of absorption. Judging bioavailability only by the highest concentration can be misleading because elimination starts as soon as the drug enters the bloodstream. The time when the concentration is highest, also known as peak time, is a common measure of how quickly the drug is absorbed. Later peaks indicate slower absorption. I also want to mention that intravenous administration is the golden standard regarding bioavailability because 100% of the drug arrives in circulation virtually instantly, giving this method a bioavailability of 100%. On the other hand, oral medications face stomach acidity and are absorbed by the digestive tract. Digestive enzymes start metabolizing the drugs, reducing the amount reaching circulation. These drugs undergo first-pass effect. This means that the liver, gut wall, and digestive enzymes process some quantities of the medication, lowering the amount that enters circulation and therefore reducing bioavailability. This is opposed to drugs given intravenously, which enter the systemic circulation directly. So, to summarize, first pass effect is a pre-systematic metabolism which reduces bioavailability. Medication undergoes metabolism at a specific location in the body. The first pass effect decreases the active drug concentration upon reaching systemic circulation or its site of action. The first pass effect is often associated with the liver, which is a major site of drug metabolism. However, the first pass effect can also occur in lungs, gastrointestinal tract, and other metabolically active tissues. Here is a graph describing first pass effect. We see spiking concentration, which then decreases. Now, why is knowing first pass effect so important? The clinical significance of the first pass effect is crucial for creating a proper pharmacotherapy. Drugs that undergo considerable first pass effect include alpranolol, morphine, and mercaptopurine. When these medications are given orally, they are quickly metabolized via the first pass effect, requiring their oral doses to be much larger than their intravenous doses. Also, a good example for first-pass effect is nitroglycerin. Although nitroglycerin administered orally is readily absorbed, it is extensively metabolized during the first pass through the liver. This is why nitroglycerin is typically taken sublingually, where it enters the circulation and is delivered directly to the heart without having to go through the liver first, and therefore avoiding the first pass effect. Isosorbide mononitrate differs from nitroglycerin. It undergoes minimal first-pass metabolism, which leads to high bioavailability after oral administration. Distribution is how a drug spreads in the body, and it is influenced by how well it dissolves in fat, blood flow, and capillary permeability. Larger, heavy drugs often stick to proteins, leading to higher concentrations in the blood and a smaller distribution area. Smaller molecules spread widely into tissues, resulting in a larger distribution area. There is a measure called volume of distribution that can indicate if a drug stays in the blood or moves into tissues. It can be described as amount of drug in the body divided by plasma concentration of drug. Based on this equation, we can conclude that a drug with a high volume of distribution has a tendency to leave the plasma and enter the extravascular parts of the body, and this means that a higher dose of a drug is required to achieve a given plasma concentration. On the other hand, a drug with a low volume of distribution has a tendency to remain in the plasma, meaning a lower dose of a drug is required to achieve a given plasma concentration. Elimination is a reversible loss of drug from the body. It occurs by two processes, metabolism and excretion. Excretion involves loss of chemically unchanged drug, whereas metabolism is conversion of one chemical entity to another. Main routes by which drugs and their metabolites leave the body are kidneys, hepatobiliary system, and lungs. Lungs are important for gaseous anesthetics. Most drugs leave the body in urine, either unchanged or as polar metabolites. Here the kidneys are a crucial route. However, lipophilic substances are not eliminated efficiently by the kidney. Most lipophilic drugs are metabolized to more polar products, which are then excreted in urine. This happens mostly in the liver, mainly by cytochrome P450 system. This is a large enzyme family essential for drug metabolism. Drug metabolism involves two kinds of biochemical reactions known as phase 1 and phase 2 reactions, which often happen sequentially. Phase 1 consists of oxidation, reduction, or hydrolysis, whereas phase 2 reactions involve conjugation. Metabolites of phase 1 are often more chemically reactive than the parent drug, and this is because they introduce a relatively reactive group into the molecule, such as hydroxyl, which then serves as a point of attack for a conjugating system to attach a substituent such as glucuronide. The groups most involved in conjugate formation are glucuronal, sulfate, methyl, acetyl, glycyl, and glutathione. Phase 2 results in inactive compounds, and these two phases decrease lipid solubility, which results in increased renal elimination. When we talk about elimination, we need to mention first-order kinetics and zero-order kinetics. First-order kinetics is where a constant fraction of drug in the body is eliminated per unit of time. The rate of drug elimination is directly proportional to drug concentration. The drug concentration halves predictably according to fixed time intervals. If you plot the relationship of concentration versus elimination rate, the relationship is linear. The relationship of concentration and time is linear if we plot this on a semi-logarithmic scale. Zero-order kinetics undergo constant elimination regardless of the plasma concentration. The relationship of a concentration to reaction rate can be plotted as a straight line. The difference between zero and first order kinetics is their elimination rate compared to total plasma concentration. When giving medications, we must fully understand the mechanism of action and elimination to reduce any side effects. And when treating a patient who may have ingested a toxic quantity of a drug, knowing that drug's elimination properties helps treatment and the disease course. A good example for this is methanol. In case of a methanol ingestion, urgent treatment is necessary, and this is because methanol follows zero-order kinetics, and the toxicity of methanol is not in the amount of ingested methanol, but in its metabolites. Before I end the video, I also want to add that the way a drug works, besides drug's properties, also heavily depends on the patient's characteristics, such as kidney function, genetics, gender, age. All of these things can help predict how drugs behave. For instance, certain drugs may have a longer half-life in geriatric patients, and this is why drug administration should be tailored to each patient's needs. Understanding pharmacokinetic principles helps healthcare professionals to adjust doses more accurately.